Fontan procedure. So that's why, like it's called the Fontan kreutzer after her dad. So it's my real pleasure to be here today. All right. So the objectives for this talk is that we're going to talk a little bit about the long-term outcomes after the Fontan-Kreutzer operation. We will discuss the role of cardiac imaging post-Fontan-Kreutzer, and then we will discuss the multi-center force registry, which is an up-and-coming registry. As an introduction, the first Fontan-Kreutzer procedure was performed in 1969 and was reported in January 1971 by Dr. Fontan. It did not look like anything we know right now. It had a pulmonary homograft from the IVC to the atrium, and then an aortic valve homograft from the atrium to the left pulmonary artery. Well, there was a classic gland where the SVC is connected to the right pulmonary artery. And then at the same time in Argentina, so Dr. Kreutzer performed the first atriopulmonary Fontan using one homograft. So just one homograft from the right atrium towards the branched pulmonary arteries. And interestingly, Dr. Kreutzer was unaware of Dr. Fontan's work at that time. Dr. Fontan was in France and Dr. Kreutzer was in Argentina. And they didn't know about the work that each other was doing, but they were both tackling the same problem, which is how to palliate these patients with single ventricle. So this is the, like how this all started. So in 1969, there was the creation of the Fontan-Kreutzer procedure. In the 1970s, there was multiple modifications, starting with removal of the valved conduits and the creation of the atriopulmonary Fontan by Dr. Kreutzer. And then in the 90s, there was the creation of cavopulmonary anastomosis, including the lateral tunnel and the extracardiac conduit Fontan, with improved operative survival. Now, this talk is obviously it's meant to be a discussion. So if at any point you have questions, please feel free to stop me and ask questions. And then today in 2024, we have older patients and we have adults actually with the Fontan-Kreutzer operation. And it's time to focus on long-term morbidity and mortality in these patients. So how does the long-term outcomes look like? This study is from the United Kingdom, looking at 7,000 patients with adult congenital heart disease, and they had a median follow-up of 9 years, and they compared survival to an age and sex matched group of adults in the United Kingdom. And what you can see in this, this is looking at the standardized mortality ratio for different types of congenital heart disease, and you see that the Fontan circulation had the highest standardized mortality ratio compared to any other type of congenital heart disease in adults. So that standardized mortality ratio in Fontan is like 23, so meaning that they have 23 times more risk of death compared to the normal population. And then they did something really interesting here. So they took a 40-year-old with different types of congenital heart disease, and they plotted an equivalent age for them based on the 5-year risk of death. So what you notice here is that for a 40-year-old Fontan, their risk of death is similar to someone with who's like 75 or older without congenital heart disease. So certainly a high-risk population. And that was higher than patients with Eisenmenger syndrome or patients with complex congenital heart disease or patients with systemic RV. So the Fontan population has the highest risk for death compared to any other types of congenital heart disease. And then in this table, they did the same thing. So they took the actual patient age here, and then they put here the equivalent age based on the 5-year risk of death. And you see that Fontan, who's a 20-year-old, has a similar risk of death to for a patient who's 64 without congenital heart disease. A 40-year-old has a similar risk of death to a 75-year-old. So definitely they age much quicker than other patients without congenital heart disease. This study, our group did in 2017. I was a cardiology fellow at that time. And what we did a meta-analysis looking at the causes and the risk factors for mortality in patients with the Fontan-Kreutzer. We looked at all publications at that time from 1990 to 2015. The operation date was between 1973 and 2013. And this meta-analysis, where we kind of like, reviewed all the literature, has 6,700 patients, so a lot of patients from 15 studies. The mortality was, there was like 1,000 reported mortalities, and the cause of death was known in about 700 of these patients. And when we looked at what causes them to die, the most common cause, as you would expect, is heart failure or Fontan failure. So that's not surprising. But then we found that the second most common was sudden death. And then all other organ systems can contribute to their mortality. So respiratory failure, renal disease, thromboembolism, infection, protein losing enteropathy, liver disease, and malignancy, or were reported causes of death in patients with single ventricle. So it's not just like a heart issue, it's a multi-organ issue. So based on that, currently we think about these patients with single ventricle as they go through a journey through multiple stages, like starting with stage 1 to the gland, to the Fontan kreutzer operation, and many of them require a heart or heart liver transplantation. And like one of the things I do, like a Fontan clinic, and our goal in that Fontan clinic, Fontan kreutzer clinic, is to delay or prevent transplantation and refer them at the right time when they are like, strong enough to tolerate transplantation without dying from the transplant post-Fontan kreutzer. So I will present a case right now of a 24-year-old with hypoplastic left heart syndrome, just to kind of like, talk about the imaging in Fontan. So this is a 24-year-old hypoplastic left heart syndrome, had aortic atresia and mitral atresia, had done like, a Norwood procedure, then a Glenn procedure, then the Fontan kreutzer procedure. And he had a baseline echo with low normal RV systolic function, so he was doing pretty well. However, during COVID, unfortunately, he lost to follow-up and started having some substance abuse issues. And 1 week before he came back to care, he had sudden onset chest pain while he was at the gym, while running on a treadmill. Since then, he had persistent dyspnea. He's always short of breath and has dizziness even with mild exertion. So he came into a small outside hospital. Because of the chest pain, they went ahead and they did a troponin on this kid, and it was severely elevated. They did a BMP, and that was also very high. So they did a chest CT there, and they said that there's a concern for pulmonary embolus in the left pulmonary artery. And they transferred him to our hospital emergency department. And our hospital is very familiar with taking care of patients with congenital heart disease. So this is his echocardiogram from 2019. You can appreciate that this, single right ventricle seems to be working pretty well. While this is his echocardiogram when he presented in 2023. And you can appreciate that this ventricle is severely depressed. There is also a small pericardial effusion, as you can see here. And then the fellow who was doing the echo did also some sweeps. And you can see that there is like this filling defect in the right ventricle. So that's suggestive of a thrombus in that right ventricle. It's a large thrombus. And they also tried to look at the coronary arteries. And you can see that they probably got the right coronary artery here. This is the native aortic root. It's so small. This is the neo-aortic root. So it used to be the pulmonary. It's much bigger. And then when they put color over the left coronary artery, you can't see the left coronary artery. And then we also got a hold of the CT images from the outside hospital. So this is what they were concerned about, like a pulmonary embolus in the left pulmonary artery. However, this is a common artifact we see post-Fontan due to contrast timing. So you can see that the blood with contrast is coming through the gland. And there is this filling defect, but if you follow it down, you see that the Fontan doesn't have contrast yet. So it's probably just the blood coming through the Fontan and gives you this artifact that we commonly see by CT scan. So we weren't concerned about a embolus in that left pulmonary artery. However, when we looked carefully at that CT, we look at this native aortic root. So I'm gonna play it a few times. And you can see that there is likely a filling defect in that native aortic root. So this patient likely had a thrombus in that native aortic root, and that resulted in him having that severe chest pain and severe ventricular dysfunction. So just to review this a little bit more, so this is the CT report. So from the outside hospital, they thought it's a left pulmonary artery large embolus. When we reviewed it, we thought that this embolus is an artifact, and we thought that the left pulmonary artery thrombus is less likely. However, we were concerned that there is a native aortic thrombus in this patient. And just to quickly talk about the pros and cons of the CT. So the CT is great because you can get it rapidly, rapid acquisition. It gives you high resolution. You can see small things, and it can visualize the Fontan pathway. However, the cons of it is that it involves radiation with CT. So especially in smaller kids, you don't want to give a lot of radiation. It doesn't give you any flow data. And then the contrast timing can be tricky in these Fontan kreutzer patients. So a lot of times you do not opacify the Fontan pathway, and you end up with artifact that looks like a thrombus in the branched pulmonary arteries. So just to summarize this case, so we were concerned about a thrombus in the native aortic root, as you can see it here. And then in retrospect, when we review that echo, you can see that there is maybe something, the left coronary origin is here, but there's maybe something, and that's why we can't fill that left coronary artery with color. So likely there is a thrombus at the origin of that left coronary artery. Now, obviously, this patient comes on a Friday night, as usually sick patients come on a Friday night, and then he goes to the, this is just like showing that where we were concerned about the thrombus. He goes to the cath lab the next day, and when they inject in the native aortic root, you notice this is that filling defect that we saw by CT. So there is actually a thrombus in that native aortic root. And that is causing, that probably caused some obstruction of the left coronary artery and resulted in that chest pain. But now at the time of the cath, you can see flow in both coronary arteries. And his function was severely depressed. So they felt that it's very high risk to try to take that thrombus out. So they made the diagnosis of a thrombus in the native aortic root. Now, when we look at the cardiac MRI a few days later, this is his right ventricle. You notice that his right ventricle has severely depressed function, and it's a little dyskinetic. So this area here comes in, this area comes out. So, and then we did the late gadolinium enhancement imaging, which is the image where we look for a scar. And the normal myocardium, the normal heart looks black in this image, while if there is any scar, it looks white. And you can see that this patient has a very large scar in his right ventricle. So he likely just infarcted most of his right ventricle due to that thrombus in the native aortic root. So that was a very unfortunate event in this patient. So the way we managed this patient got admitted to the cardiac ICU. And we tried some medical management in this patient, but the patient didn't, didn't improve that much. So he underwent a successful ventricular assist device implantation, and he's now outpatient with a ventricular assist device. So just quickly to talk about ventricular assist devices in the single ventricle, the device that we use in the United States mostly is the HeartMate 3. I don't know if the same device that is available in Argentina or if you have another device available, but we use the HeartMate 3 a lot for a lot of our patients. The nice thing about it is that it's intracorporeal, so it stays inside the body. It has continuous flow, so less risk of clotting. It's dischargeable, so you can send the patient home with it. It has excellent hemocompatibility profile, so less thrombosis. And we can use it even in smaller patients who are like 20 to 25 kilograms. But in these patients, we like usually scan first, make sure that the chest is big enough so it can fit that device. Typically, it has an inflow cannula in the ventricle and then an outflow cannula in the aorta. So how do the outcomes look like for the systemic ventricular assist device in Fontan patients? This is a study, like a large registry study. from the PDMAX, which is the pediatric device registry. And that study was published in 2022 from multiple institutions. And it actually had 55 people with single ventricle who underwent ventricular assist device and had a positive outcome in 81% of them at 6 months. So they were either transplanted or they still had the device at 6 months and they were alive. Interestingly, 50% of the death occurred in the first 2 weeks of support. So usually if they are going to have a bad outcome, it happens quickly after the device. And the median length of support in that study was 4 months. These are the complications. So thrombosis was seen in about 4%, stroke in 5%, GI bleed in 7%, and non-GI bleeds in 9%. So, like it's a risky surgery. It's not like a low risk, and there's high mortality and morbidity. And the key here is not to wait too long to put a mechanical support or a ventricular assist device. So do not wait until the patient is is on the cliff edge, because in that study, when they look at their data, you can see that the red line here is the patients who were not on ECMO. The blue line is the mortality for the patients on ECMO. So you see that if the patients were on ECMO during this hospitalization, and then you put the ventricular assist device, their mortality is a lot higher than the patients who are not on ECMO, and you kind of like electively put a ventricular assist device in them. So, the key here is like early referral for a device. So, as cardiologists, we partner with the surgeons and with the heart failure specialist, and we refer them early in the process of Fontan kreutzer failure. And Fontan patients who are undergoing elective ventricular assist device support can do well, actually. While 20 to 30% of patients in the current series are bridging via ECMO before the ventricular assist device. So they were so sick that they went on ECMO first and then on a device second. And these patients typically don't do very well. All right. So the next part of this talk, I will talk about cardiac MRI. I know that, like talking to Dr. Christian Kreutzer in Argentina, he seems like you seem to have a lot of interest in cardiac MRI and doing a lot of cardiac MRI as well. So cardiac MRI is very good for cardiac structure, to evaluate cardiac function, and to quantify flow, and also for tissue characterization. So it gives us like really good look at the cardiac anatomy. This is a patient who has a VSD, and the aorta comes from the right ventricle. So you can see nicely the anatomy. You can see the VSD very nicely, and you can see the subaortic conus very nicely here. You can look for any arch obstruction in these patients, especially in the patients who had arch surgery. And you can do a nice 3D reconstruction of that arch, and you see it very nicely. And you can also look for pulmonary artery compression, which is something that can happen, especially in these patients who had a neo-aortic dilation, something we see a lot after the Norwood operation. You see here the aorta is big and it compresses that left pulmonary artery here. And you can also look for Fontan pathway obstruction. This is something we've been seeing after the extracardiac conduit in older patients. You can see this patient, the tail end of that extracardiac conduit seems pretty narrowed while the IVC is dilated. And this patient here has an extracardiac conduit that stayed the same size. However, the patient is now much older, and you can see that the IVC and the hepatic vein are a lot bigger than the conduit itself. And then we can also look at the function and flow very nicely by cardiac MRI, and that becomes really tricky by echo, especially as the patients get older. So we can look for ventricular size, ventricular mass. We can look at ventricular function. We can do some strain analysis by cardiac MRI, like we can do by echo. And then we can look at the flow in different parts of the Fontan circuit. So we can do a 2D or 4D flow, looking at the, how much flow goes through every structure. And that can be very useful, because this is how we determine valve regurgitation by MRI, and also how we determine, how much flow goes through the SVC, how much flow comes from the IVC, how much flow goes to branch pulmonary arteries, and gives you an idea of how much collaterals these patients have. So we measure the flow in the branched pulmonary arteries and also in the pulmonary veins. And then if there are any collaterals that come kind of like distally, we can tell you how much collaterals, like, 30% of the aortic flow or 20%, depending on, these flow data. And then we can actually superimpose this flow data on the anatomical data that we got. So this is that same patient with a small conduit for his size. And you can see that, like over that conduit, like you see by echo, there is some flow acceleration. You see that red color here. And that correlates usually with some energy loss in the conduit, and also may correlate with bad outcomes in these patients. And then we can also label that blood. So this used to be like very difficult to do. You have to do like, you have to have a computational flow dynamics. And now it's like, clinically available, very easy to do. We can actually see like how much of the IVC blood goes to the right lung and how much, to the left lung and how much goes to the right lung. Same for the SVC flow, we can label it and see how much goes to each lung. And that can be very useful, especially if you're like concerned in these patients with heterotaxy who are not getting the hepatic factor to each lung. And then we can also do some tissue characterization. So this is from that patient I showed you who infarcted the right ventricle. Indeed, we ended up actually writing this case in circulation imaging just because of how extensive this right ventricular scar is in this particular patient. But all our studies that we are doing right now, a lot of them come from only like single center. And in order to really improve the outcomes for these patients, we really need to kind of like, if each one of us hold one piece of the puzzle, we need to come together and put these pieces together in order to understand what's going on with these patients. And we need to all like, from all around the world, kind of sit together, bring our heads together, bring our pieces together so we can improve the outcomes for these patients. And that's why when Dr. Berra invited me for this talk, I was so excited to talk to you about it. And there are some efforts in the field of Fontan. So this is an example called the FORCE registry or the Fontan outcome registry using cardiac MRI examination. It is a registry that is multi-institutional, includes a lot of centers from around the world. And, like this registry launched in 2020, by multiple people, especially Dr. Rahul Rathod in Boston. I know Dr. Berra has done his training in Boston. And in 2022, they built a nice research platform, while in 2023, they are working on making this FORCE registry a service for centers who participate to help them with cardiac MRI. So this is how it started. It was kind of like, building a plane as it's flying. So everyone was trying to figure things out quickly. And now it has like, more than 35 centers in the United States and in Europe, in Canada as well. And I think there are a couple of centers from South America who are completing the regulatory paperwork so they can join this registry. And it involves not just the clinical or surgical history and testing data, which is housed in REDCap registry, but it's also, which is kind of like, a cloud-based system. It also have actual MRI images. So if you're asking any questions, like, let's say you're asking if the lateral tunnel is better than the extracardiac conduit, and you want to make some measurements of that conduit later on, you can actually have access to the images and do these measurements. And thus it will give you some powerful results for research and clinical care. And it now includes more than 3,500 patients with Fontan. So this is now the largest Fontan data set in the world. And the way, now, previously, if you need to do like a cardiac MRI in a Fontan patient, it takes a physician about an hour to do like all the contouring and the post-processing for cardiac MRI for these for these cardiac MRI images. And now they partner with machine learning, and now the computer can do it for you through the FORCE registry for about 30 to 60 seconds. So that will save the physician a lot of time. So the way this is supposed to work is that the patient comes, get their cardiac images, their images get uploaded to a cloud server in the FORCE registry, and then that does all the post-processing and give you the information. And this way, this will democratize where this cardiac MRI needs to be performed. It doesn't need to be performed in a children's hospital, can be performed anywhere, and the machine can analyze the data and give it to the physician. And because the force registry also has the clinical data for the patients, they will also be able to hopefully provide a 5-year risk score for death or transplantation. So it may be able to tell you, okay, this patient has high risk for transplantation. You better start that discussion with the family, or discuss maybe doing a ventricular assist device in these patients. So to conclude, we covered a lot of ground over the last 30 minutes. We talked about the journey of these patients with single ventricle from stage 1 to Fontan kreutzer, and that many of them may require heart or heart-liver transplantation or a ventricular assist device, and that multimodality imaging can play a central role in risk stratification for these patients. We also talked about our goal as cardiologists and cardiac surgeons is to try to delay or prevent transplantation and refer them at the right time when they are strong enough so they can tolerate any further surgery. And we talked a little bit about the multinational, multi-institutional force registry, and I'm hopeful that your center and other centers in Argentina can join us so we can all put these pieces of the puzzle together to help these patients. And with that, I'm very thankful to all of you, and I'm happy to take questions.
Thank you very much, Dr. Tarek Al-Sayed. This is very important to give your knowledge to us. I am so happy you show very nice project about the force program and all of these things that you show. Someone in the audience has any question, please go ahead.
Dr. Neroti?
Yes, who want to talk?
I see Dr. Neroti has a question.
Okay, Rodolfo, please go ahead with your question.
I think you may still be muted, Dr. Neroti. Dr. Neroti, Dr. Rodolfo Neroti, do you have a question? I think you may still be muted. We can't hear you.
Yes, Rodolfo, no se te escucha. No se te escucha la pregunta, estás bloqueado el micrófono. Tenés bloqueado el micrófono, Rodolfo. No se te escucha. Okay, I can't listen you, Rodolfo. You are muted. Someone else has another question? I have some questions. You showed the MRI flow dynamics, and do you use in every patient this methodology with multi-diagnostic images? When you use before the Fontan or after the Fontan?
So we've been using it mostly after the Fontan, Ignacio. We use it usually when they are teenagers, and this is usually when they start getting the the problems. So we use it when they are starting at the age of 8 or 9, when they don't require anesthesia for cardiac MRI or sedation. And initially we started using it just if there is a clinical concern. But now the cardiologists like it so much that they send, they do it as part of routine screening. So they do it every 3 to 5 years, and they do it instead of echo that year. Instead of sending the patient to do an echocardiogram, they just do a cardiac MRI, because you get the same information from echo, but you also get information about the Fontan pathway, which you don't see well by echo, if there's any narrowing. You get information about like how much flow goes to each lung, which you will not get by echo. And so that has been like, you know, the nice thing that the cardiologists like. And then also like, especially with this systemic right ventricle, it's hard to know what the ventricle function looks like by echo until it's severely depressed. So by MRI, you can actually quantify it and see if it's deteriorating. So you could get a lot of good information from MRI.
Okay, thank you very much. And do you, which parameter always in your protocol do you make in every pre-Fontan strategy? Which diagnostic do you use? Echo, cath lab, and tomography or not? What do you do?
So mostly in Pittsburgh, Ignacio, we use echo and cath lab. In Boston, like, you know, during training, we did some MRI pre-Fontan. We don't do it in Pittsburgh just for logistical reason. It's just hard to coordinate the anesthesia between the cath lab and the MRI scanner at the same day. But now we're getting a new scanner that's like, you know, very close to the cath lab, where you can just do it with one anesthesia, and we'll start doing it before the Fontan surgery. But everyone still gets a cath and an echocardiogram.
Okay. Did you?
Can I
Yes,
ask a
Rodolfo.
question? Yes. I mean, I didn't see any numbers here. You see, and I'm not sure about the indications, because the indication in the patient that have need a Fontan operation is extremely important. So I have not seen any information about that, and I didn't see numbers. You know, the numbers that really show is what has been done is correct, and I am not sure that what I mean. It's a very confusing presentation, very confusing.
All right, Dr. Neroti. Just to clarify, Dr. Neroti, what numbers would you have liked to
Well,
see?
number of patients, and then on top of the number of patients, the indication, when do you do a Fontan, when do you do this operation, and because there is no result here of the number of patients, mortality, complication, and other things that are extremely important.
Yep. I think that's such a good question. Like, you know,
I know that is a good question. That's why I'm asking that.
yes. So typically right now in Pittsburgh, and that wasn't part of the presentation. I was kind of more looking at the long-term outcome for this presentation. But right now in Pittsburgh, every single ventricle who's deemed to be single ventricle will end up, if they have good hemodynamics, like, you know, in the pre-Fontan catheterization, they will end up getting the Fontan kreutzer operation. So that's, you know, like, that's usually like, you know, our approach here in Pittsburgh. And I think that has been the approach in many of the North American centers. Talking to some of my friends in South America, a lot of patients may stay as a Glenn, especially if their hemodynamics were borderline. But in North America, I think people feel strongly about doing the Fontan operation. It improves the saturation and also, like, you know, improves their exercise capacity. So the mortality, I didn't put it in my presentation here, as I was looking at long-term.
Well, that's very important. You know, you don't have the number of patients, and you don't have the mortality. You know,
Yep.
they are human beings, so this is very important. I mean, you can of course open chase and do some different operation, but if the numbers are not correct, you know, it's not really I would say is not really appropriate that.
So, you know, like the mortality in the United States right now is less, like, you know, after the Fontan operation, is less than 5%. It's about 2%.
Well, I mean, I'm asking about your mortality, not the mortality in the United States.
And the more, like, you know, our mortality in Pittsburgh is very similar to the mortality in the United States. So I, you know, like, I didn't look at this particular question for this presentation, but we
Well,
the data to the Society of Thoracic Surgeons in the United States. And over the last 4 years, we don't have any mortality in Fontan patients, and we do about 25 of them a year. So it's
exactly, but what kind of operation have been doing? Because the Fontan operation can be done in different situations.
Right.
You know, the Fontan operation require a very careful selection of the patient and the indication. So the indication of what you do. I mean, they are human beings, they are patients.
I think this is such an important question. I just didn't have time to address all the, like, you know, I was looking at them more like, you know, long term, and you know, we can certainly, like, you know, find another time and talk about, like, you know, the short term outcomes and the indication for surgery.
Well, I mean, that is extremely important, you know, when you present something. The indications are extremely important, as well as the mortality, as well as the complication. You know, extremely important, and I haven't seen that here.
Yeah, and one of my disclosures is that you know, I collaborate with our cardiac surgeons very closely, but I'm actually a cardiac imager, so I thought to kind of, like, you know, give you a little more imaging kind of presentation. But I think for next time, I will make sure that we get, like, some more information about.
I mean, the imaging was not what I saw here. You know, this is something that had to be done again, you know, with a different approach, a different concept, a different trying to get more important information and results.
Okay.
Thank you.
Thank you, Dr. Nairotti, and thank you, Dr. Tarek Al-Assid. This is important, the question that Dr. Nairotti asked, and perhaps in the next lecture we can analyze, because there are a concept very, I like a concept that you show about the FORCE program, that there are a multicentric, perhaps, patients, and this perhaps will make some answer for some kind of question like Dr. Nairotti told. I think this is very important. Obviously, I appreciate a lot your knowledge, Tarek, and someone else in the audience has any question to make?
And just going back to Dr. Nairotti's question, like, you know, these are some of the criteria that were, you know, that were proposed in the 1970s about, like, you know, the indication for surgery and who's not a good Fontan candidate. But these days, I think we kind of like
that's a long time ago.
That's a long time ago. So these days, we kind of, like, you know, stretch these limits a lot to, you know, so they don't. I mean, like, we have done Fontans in patients with a pacemaker. Typically, we like them to have a pulmonary artery pressure below 15 on their cath, and then we like them to have a normal function, but we do it in patients with depressed function. We like them to have a competent AV valve, but to do it with patients with mild AV valve regurgitation, or if they have like severe AV valve regurg, we try to do the surgery for the valve regurg before the Fontan. And we like them not to have PA distortion, but sometimes you have to do some pathway during the surgery.
Well, I think it's a good that's a good thought, but then you have to select the patient. Which patient you will do? You know what would you do in each patient? Right, Fontan operation, and the Fontan circulation does not accept as error in indication.
So that would be for the next presentation.
Well, okay. Keep that in mind, because I mean you will get better results and you will lose less patients. Thank you for presenting your results.
Yep. Thanks, Dr. Note.
Thank you. And how we can add it to this force program from Garrahan?
So typically like this is the forced registry, Ignacio, is mostly patients who had cardiac MRI. So I can connect with you offline, but I can connect with the cardiac MRI cardiologist in your hospital and see if they are interested in participating. And then hopefully we can, and like this is just an example of one of the multi-institutional registry efforts. There are a couple of other examples where like people can share data and hopefully like, can come together and sit together and try to solve complex clinical problems.
Great. Okay, someone's
Nacho,
sí, yes.
Can we talk a couple of minutes?
Yes, let me finish this presentation
Good.
with Dr. Tarek. Thank you again.
And what shall I
I
call you or you call me?
I call you.
Thank you very much.
Okay, no problem. Thank you, Rodolfo. Thank you, Dr. Tarek. I appreciate a lot your presentation. For myself, is very nice. Perhaps we can do another in some months with some more data. Thank you very much. I appreciate a lot, and our center are very happy to learn with your presentation.
Yep, thank you very much, Dr. Vera. It's a true honor to have this like discussion with you, and I look forward to meeting many of you in the future and working with many of you. Thank you and have a great day.
Okay, keep in touch and good luck.
Thank you so much.
Bye.